We're very excited to be here presenting this eye-opening and very interesting case we titled Extreme Hyperinsulinemia, Not Always an Insulinoma. So our patient was a female 49-year-old. She initially consulted because she presented 2 months history of weakness, diaphoresis, and hot flashes. By these symptoms, she was initially assessed by OBGYN because it was suspected they might be related with menopause. But during their follow-up, they documented elevated insulin levels, which were over 5,000 microunits per milliliter, and that's why she was first referred to our service. So at this point, she presented no medical prior history of diabetes. She had no clinical findings that suggested the presence of insulin resistance, and also it's important to mark that she wasn't on any type of pharmacological treatment at this point. So I would like to make a quick question here. I bet if a patient presented to your clinical practice and she presented with these insulin levels and these clinical manifestations, many of us would have thought of an insulinoma, but as we're going to see further along, this wasn't the case in our patient. So on our first assessment, we decided to start with glucose monitor. As you can see, she presented glucose drops that were predominantly at night, and also they didn't follow any specific pattern. She had fluctuating glucose levels, and also the episodes of hypoglycemia were actually mild, and they correlated with the symptoms our patient presented. Later on, at this point, we had already performed a complete medical interrogation, a complete physical exam, and we confirmed she presented some traits that were compatible with Whipple's trait. So our next step was to evaluate her clinical context. She didn't present any critical illness or wasn't ill apparent, so our next step was to perform a fasting test during 72 hours. So I would like to make a quick recap of the information we have until this point. We already had documented that she presented elevated insulin levels, and also she presented mild episodes of hypoglycemia. But at this point, we had a burden of differential diagnosis, which could include endogenous hyperinsulinemia. Also, we couldn't rule out at this moment that it was a factitious hyperinsulinemia, which is also a differential diagnosis we have to take into consideration when assessing these cases, and more rare causes in our population in Latin America, which include autoimmune insulinism syndromes. So I want to make a recap in graph label B. So what we observe here in the dotted line is what our patient presented. These are the levels of insulin, which were predominantly high over time. And on contrast, the continuous line is the fluctuating glucose levels that were portrayed by our patient. In contrast of what's presented in graph A, it's what you would normally physiologically expect that would happen in the body. So back to our fasting test. In hour number 32, our patient manifested she presented the symptoms. And at this moment, we proceeded to confirm she also presented hypoglycemia. So at this moment, we took the complete panel labs, which included C-peptide, proinsulin, insulin, also ketone levels, and insulin autoantibodies. And our results were she presented elevated C-peptide, insulin, and proinsulin levels, and markedly what was our major diagnostic cue in this case, she presented elevated insulin autoantibodies, and in contrast, her ketone levels were low, also as her blood sugar. So having all this information, her clinical presentation, and also the fluctuating and the discrepancy between the biochemical profile we had and the episodes of hypoglycemia, our final diagnosis was insulin autoimmune syndrome, which is also known as Hirata syndrome. This, among Latin American population, it's actually a rare cause of hyperinsulinemic hypoglycemia. Most of the cases are reported in Asian population. It's not actually really common in my population. So it was a diagnostic challenge. In this case, also, it was important to perform a step-by-step approach because it's preventing us from performing diagnostic additional images which wouldn't have led us to our diagnosis and also prevent us from performing invasive testing. Our management in this case was conservative. We performed education on diet fractioning on our patient, and we initiated management with acarbose. And with those two interventions, she evolved clinically satisfactory. Over the next 3 weeks of follow-up, she didn't present any more her symptoms, and her quality of life improved significantly. So a few learning points we want you to take from this case is, first of all, hyperinsulinism is not a diagnosis by itself. It's a diagnostic clue, and you have to take into consideration the clinical manifestations the patient has. As in this case, even though she presented extremely elevated insulin levels, her hypoglycemias were low, and they didn't follow any specific pattern. They were predominantly at night, not during fasting periods. Also, a step-by-step approach, and I think this is one of the most valuable lessons of this. As our clinicians, we have to guide our evaluation by step, and also always take into consideration the widest spectrum of differential diagnosis we can have. Thank you very much.